Good morning. Let's talk about danger in psychiatric patients, and what I'll do is give you a few brief anecdotes and then some comments of what my thinking about them is. So first example happened when I was a resident. I was at a VA hospital at night and I was sitting in the psychiatric emergency room with a patient, and the interview was going fine. He was happy to talk with me, and I listened to him, and finally my thinking was he did not need to be admitted to a psychiatric hospital, so everything was fine in the interview until that point, until I mentioned the word shelter, because I felt he did not need to be in the hospital. He had no place to go. He'd been kicked out of a group home, when he heard the word shelter, he got up in the emergency room at the VA hospital, and they had security there, but they weren't necessarily right next to the patient. So he got up when he heard the word shelter, took a bottle of medicine out of his pocket, excuse me, and then swallowed the whole bottle of medicine right in front of me before security could stop him, before I could stop him. So that's one example of danger to self. And I think that shows that suicidal ideation are almost never black or white issues. There's almost no one who 100% wants to kill themselves. And there are very few people who've never been depressed or potentially thought about suicide. So, or at least it's maybe crossed their mind. So it's not a black or white issue. So this example, I think, illustrates that suicide is not a black or white issue. He ingested the whole bottle of his medication, which was Klonopin, luckily not a very lethal medication, and he ended up in the medical ICU. So he was not admitted to psychiatry yet. I mean, he went to the ICU, so in a way, he was able to get into the hospital, not the way he wanted to get in, of course. And then after the ICU stay, he was transferred to psychiatry. All right, so that's one example with a few thoughts about that. Another example is a gentleman who had tried to commit suicide by jumping in front of a subway train, a serious attempt. He was not seriously injured. The subway train was able to stop. Actually, I do think he was injured to a certain extent, but he did not require surgery, at least nothing major. And he was on the medical psychiatric combined ward. And this was a day or two after he'd been admitted. And I saw him standing in the hallway. There was disco music playing. He was dancing. And the nurse around that time came to me and said, we're short-staffed. He's on a 1-to-1 suicide watch. Do we really need that watch? And I felt, wow, do I want to relieve the staff a little bit? Maybe it's a good idea. But in my gut, I did have some concerns, and you do want to listen to your gut, which I did not do enough at that point. And I said, okay, we'll take him off the 1-to-1 suicide watch, which means he would be observed every 15 minutes. And then a little bit later, maybe an hour later, the other psychiatrist, the chief of the unit, came to me and said, Peter, so-and-so just hung up, tried to hang himself. And he was still alive at that point. He tried to hang himself with a sheet on a door. And he was still alive at that point. He was transferred to, I think, again, a medical ICU. And unfortunately, he did die maybe a week later. So that example shows that it's really important to go with what you feel is correct for the patient in their best interest clinically as a psychiatrist, and not have your arm twist it or not, set those boundaries, not let anyone push you to discharge a patient or to take them off a one-to-one suicide watch if you don't think they're ready. Because in medicine, unfortunately, especially in recent decades, there's a lot of financial pressure from outside, from insurance companies, by administrators in the hospital. So again, I think this example shows it's really important to stand your ground for the patient. Another quick example, another patient, a man in the hospital, he was very depressed. He was actually on an open ward, not a locked ward. He was very depressed, but also very irritable. And that example taught me that it's very important to realize that irritability and depression are a very volatile combination, a very dangerous combination, anger and depression at the same time. And I talked to him daily, and he was very angry, irritable, denied active suicidal thoughts. Unfortunately, though, a few days later, he jumped off a bridge. He walked off the ward and jumped off a bridge and killed himself. So again, what I took away from that was irritability and depression together are a very dangerous combination as far as the safety of the patient. And of course, this gentleman in hindsight would have been better off on a locked ward, not an open ward. Another example of this time danger to others is there was a patient of mine, grossly psychotic. I remember seeing him in the dining area, and he was bending over backwards and I think almost touching the ground with his hands. And another patient came to me and said, "Doc, can't you see your patient's having a seizure? Do something." I don't think he was having a seizure, but he was pretty bizarre, very psychotic, and if I recall correctly, he had some physical brain abnormalities, maybe from an injury. And he had been started on a low dose of an antipsychotic, not a very high dose at all. And within a few days, he actually assaulted me. He didn't hurt me. He was kind of ambivalent, I think. He asked me to shake his hand, and then he wouldn't let go, and then he tried to, push me or something. Nothing, I didn't get injured, but it was still a wake-up call in the sense that this patient was on a low dose of an antipsychotic. You need to, in my opinion, it's very important to give people an appropriate dose of medication. And I think that situation really brought that home. That really made that point that if someone's not adequately on an adequate dose of medication, it's hard for them to improve. He was not unwilling to take medicine. All right. Another example is, again, danger to others. A patient on the ward, I think I was relatively close by, he just punched his psychiatrist in the jaw, another psychiatrist, but a large male aide immediately tackled the patient before he could deliver another punch. So that example I'm bringing up because aides on the ward, staff members, if possible, big staff members, at least back then, to me, seemed crucial for safety. Not intimidating. They were nice guys. They did not intervene unless they had to. But if you don't have them around, once something happens, you can really be in trouble, because to call the team, there's a team of people you call for, assault situations. That back then could take quite a while. They had to take the elevator, so it could take even 5 or 10 minutes for them to come. And by that time, the psychiatrist could have been seriously injured. All right, maybe one more example. A middle-aged gentleman, I remember the guy well. He'd had surgery, abdominal surgery, and was very upset about that. He felt he wasn't attractive anymore. He'd been released from prison. He'd served time for murder. And he was in the hospital very depressed, and he had a history of drug use, including IV heroin use. And he was middle-aged and homeless. And he was feeling that he should not be discharged. This patient himself said, please don't discharge me. I don't think I can function in the community, even though he was not acutely suicidal at that point. Unfortunately, I went to a conference for a week, and while I was out, and actually before I left, I told the patient, just in case they do discharge you, please come right back to the hospital if you don't feel safe. And he, in the first place, didn't feel safe. So while I was out that week, unfortunately, he was discharged after pressure from one of the administrators. And again, that's the same issue. I think we really need to stand our ground with administrators, with insurances, with any pressure. The basic clinical psychiatric issues are the most important. So this gentleman, unfortunately, was discharged, and he ended up overdosing on heroin, and he was found, though, alive, but he was brought to the hospital then, and again went to the ICU, but he then did die after about a week, unfortunately. So again, this situation again illustrates that it's really important to set our boundaries in general, but specifically to set our boundaries when we're treating patients and do the right thing, even if, theoretically we could get fired for standing up to an administrator or, refusing to discharge a patient. It's worth it. We don't want patients to die. All right, thank you.